Hello guys, uh, today we will discuss about the dyshyperkalemia. We will just discuss about the management of dyshyperkalemia in a summary. So let me start with the pain. So dyshyperkalemia. My handwriting will be slightly rough, but just for understanding. So we will start with potassium. So potassium have two things. There is hypokalemia and there is hypokalemia. Okay. So first of all we will read about hyperkalemia. So we will only discuss about the management. So in the management, first thing we have to protect the heart. We have to protect the heart. For that we will give 10 ml of 10% calcium gluconate in 100 ml NS in 10 minutes. First thing it is. Second, anything increasing the potassium, like potassium sparing drugs, sir. Sparing drugs. Similarly, we have another thing, we like having more potassium in diet. Have more potassium in the diet. That is one of the thing. So we should avoid that. And the most important treatment is insulin therapy. Insulin helps to transfer the potassium into the cell. So insulin we have to give 10 units plus 50 ml of 50% we have to give glucose IV in 10 to 15 minutes. That is the treatment. Similarly, we have to also treat for acidosis. So we give sodium bicarbonate. Similarly, we know salbutamol causes hypokalemia. So it can be used as yes, it can be used in hyperkalemia. That is salbutamol. You write this, and another, after you correct the acute condition, then we can give potassium binders, which decreases the absorption from the gut. Named example is that is sodium polystyrene sulfonate resin. And similarly, at last, that is hemodialysis. So basically this is the treatment of hyperkalemia. Protect the heart with this, and then anything increasing the potassium, use that, remove that one. Then there is treatment of this. Now for hypokalemia we will give normally by oral feeds is hyperkalemia, sorry, not hypokalemia, it's hypokalemia gets treated. So the dose is 20 to 40 millimole per day. It is sufficient, but in some cases like diabetic ketoacidosis, cardiac arrhythmia, and at last severe hypokalemia. We have to give parenteral potassium. So the dose is 40 millimole potassium chloride in 1 liter NS, and 1 liter NS in a dose of 10 millimole per hour, not more than 20 millimole per hour over 4 hours. You should not increase this, but this, not over 4 hours. And check ECG every 4 hourly, ECG and plasma potassium every 4 hourly, and continue IV potassium, continue it until it is normal. This is the treatment. Similarly, if by doing this also, by this above doses not being corrected, then go to treat hypomagnesemia. Treat for this, and then treat the underlying cause. Like stop the diuretics, similarly stop the laxatives and potassium binders. Stop potassium binders. So this is for this video. We discussed about the hyper and hypokalemia. In hyperkalemia, we can treat by this. This is just a brief how to write in exam. This is hypokalemia, and this is for the severe, some case not it is, some case like DKA or arrhythmia and severe hypokalemia. Parenteral potassium is the first thing you have to do during these doses, and if above doesn't work, we go for to treat the hypokalemia, because the hypokalemia also decreases due to the decreased hypomagnesemia. There is an improvement in that. There is no improvement in the treatment. Similarly, treat for the underlying cause, like we can go for stop diuretics and to stopping the laxatives and binders. Thank you.